of impact of multiple treatment intervention in early life and overall development. Operative complications might be reduced by delaying the age of initial implantation of the rods, using dual rods, submuscular implantation, limiting the time of lengthening procedure, thereby reducing the number of unplanned surgeries. These are some of the papers that I published about the APC in global spine journals, if somebody would like to look at them. Now, take-home message. In general, stick to the principles. Refer the patient to the appropriate specialist. Don't just say this myth, wait until they grow, until they become 18. This is a crap. You need to assess the patient appropriately. Do the surgery with the scars that you have, but stick to the principles. I mean, for example, when I talk about the APC technique, it's in the general methodology of the non-fusion technique. You cannot say because I don't have, for example, facilities, I would do a fusion in situ. It's absolutely contrary. You need to be on universal standards, but within the context that you have. Do what is most appropriate related to your experience and try to be updated. Don't hesitate to ask for help. Teamwork process. Now, this is a book that we published in the Taylor & Francis, through Taylor & Francis Company, based in England, about how to implement early onset scoliosis in countries with limited resources. This is, I think, the first book that talks about this thing specifically. It was published 1.5 years ago, and we had 27 leaders that wrote chapters about this. And I was luckily the main co-editor, I'm sorry. And these are blended learning courses that we have done through Will Cornell in Tanzania for the COSEXA region, and a blended learning course also in Latin America that we give them more information about early onset scoliosis, how to manage that. Hopefully we can do something in our region. It's very effective, and actually we had a paper that was accepted in the AO Spine in Las Vegas about the efficiency of the blended learning course experience that we had in Africa. Thank you very much.
Thank you. Thank you very much. It was very interesting with your new approach with the... No. We'll go ahead with the next lectures. It was very interesting, including growth arrest with distraction. We'll go ahead with the next lecture. We are very happy to have with us Dr. Lotfi Miladi from France to share with us his large experience in scoliosis treatment. We'll talk about bipolar fuseless instrumentations. I'm sure he will give us many new tricks for this method.
Thank you. Thank you for SOTCOT committee for their invitation. Okay, I will speak about another kind of fusionless surgery, the bipolar technique. As an introduction, you know that a normal spine is straight and a deformed spine is shortened. So we can tell that the hypothesis is very simple. if you avoid the spinal shortening, you can avoid the spinal deformity. There is no spinal deformity if there is no spinal shortening. And if you see in the literature, you can find that the ancient technique of correction was based on the traction, and even in Arabic civilization. So now the most common technique used is the segmental instrumentation, using as correction the rod rotation, the in situ bending, vertebral translation, associating osteotomies and VCR. And it is the segmental derotation. That means you derotate level by level. And in the bipolar technique, you avoid the spinal collapse between the two extremities of the construct, and you obtain a global distortion of the spine thanks to distraction between to the end of the construct. How work this concept? This concept is a gradual correction obtained thanks to a progressive viscoelastic relaxation of the soft tissues under permanent tension in the bipolar construct. This theory is not new. Many kind of external correction methods used this progressive correction by elongation, like with Cottrell auto-elongation technique, the Stagnara cast, the allogravity correction, or by Elizarov frame, a progressive correction obtained thanks to gradual distraction. And the technique was used by internal methods, and the first one was the Harrington technique that was based on the bipolar fixation with progressive distraction step by step. And more recently, the growing rod systems based on distraction used this concept for progressive correction, as you can see here, the gradual correction obtained by distraction. So in this concept, with the internal systems, the correction is obtained thanks to the viscoelastic relaxation of soft tissues and even of bone. And here you can see the curve of the correction, progressive correction with time and under the permanent or continuous distraction. And here you can see with this instructive case how we can obtain a progressive correction of this 137 degrees initial curve Cobb angle to almost complete correction thanks to progressive distraction. This concept needs the respect of some condition. The first one is to perform a very strong and stable fixation. Proximally, we recommend to use Hooke's claws and distally pedicle screws on lumbar area or iliosacral fixation for neuromuscular deformities. The second condition is the intermediate area preservation to avoid the fibrosis and autofusion and the crankshaft phenomenon. And the third condition is to maintain a continuous distraction between the two ends of the construct by repetitive rod lengthening by surgery or by using some expandable devices like Phoenix rod that we used at Saint Vincent de Paul Hospital 20 years ago, by magic rod, or by the new self-growing rod that we are using now. And the fourth condition for us is to start the treatment before the surgery by progressive correction of the deformity before the surgery. Some colleagues was afraid about the solidity of the construct and the risk of root fracture. David Pauly, an American surgeon, performed some studies